My name is Annabella Marte, and I will be discussing preventable causes of maternal morbidity and mortality. Maternal morbidity refers to maternal health problems related to pregnancy and giving birth that occur during pregnancy, during delivery, and after a pregnancy ends. These health problems can include infection, heart disease, diabetes, high blood pressure, blood clots, and depression and anxiety. Unlike maternal morbidity, maternal mortality refers to death caused or related to issues from pregnancy. Causes for maternal mortality include severe bleeding, hemorrhaging, infection, preeclampsia and eclampsia, complications from delivery, and unsafe abortions. Globally, 810 women a day die due to complications related to pregnancy and childbirth. These women who die mostly die from preventable or treatable issues, and many more suffer from maternal morbidity. The maternal morbidity and mortality rate between 2000 to 2017 declined by more than a third. However, recently with the COVID-19 pandemic, there has been a major disruption to health services, specifically for women, that have exacerbated the risk of morbidity and mortality for women, and more specifically for the most vulnerable and most affected groups of women. Discussing preventable causes of maternal morbidity and mortality, the history of childbirth and pregnancy in relation to women's health must first be examined. Well, today, for instance, places like the United States have a statistic of 15 out of every 100,000 births resulting in maternal mortality. The rate of maternal morbidity and mortality was much higher in the past. In the 1600s and 1700s, for instance, more than 1,200 women per 100,000 births would die, which translates to 1 and 1.5% of women in total. Some of the most common causes of maternal mortality at the time included hemorrhaging and eclampsia, as well as puerperal fever and obstructed labor. Puerperal fever, which is also known as postpartum sepsis, was historically one of the most common causes of maternal mortality, and was usually an infection that would be contracted during childbirth and would be left untreated. Obstructed labor was also fairly common, as babies would get stuck in the birth canal, resulting in mortality for both the mother and child. In particular, obstructed labor occurred commonly due to the fetus gestation period lasting longer than 40 weeks. Compared to other animals, human infants are born underdeveloped due to the maximum gestation period in the womb that is sustainable for mothers. If a human fetus were to give birth past the permissible gestation period, the fetus's head would be too big to pass through the pelvic girdle, which could potentially cause obstructed labor, as well as cause issues after birth, such as issues walking and painful intercourse. Despite the average lifespan doubling in the last 150 years, and the maternal mortality and morbidity rates declining, the history behind the medical accessibility and practices of childbirth and pregnancy, and overall how women's health was handled in the past, is a crucial factor for the maternal morbidity and mortality rates being so high. Historically, in Europe and the United States, for instance, midwives were often present during childbirth, with their skill set ranging from incompetent to highly skilled. Unlike midwives, however, doctors were relatively uninvolved with the childbirth process due to the cultural norms at the time, considering it an obscene act for a man to be present during childbirth. In the 1800s, however, doctors became more present in childbirth due to the growth of the profession of medicine. For instance, general practitioners were often involved in childbirth, but lacked training due to childbirth being considered a low-status specialty in most medical schools. At this time, due to the lack of commonly used medical devices, such as forceps that are often used for childbirth, babies who were stuck in the birth canal were often dragged out by doctors in pieces, with midwives cracking the skull of the child and killing it to save the mother, and doctors breaking the pubic bone to birth the baby, which often resulted in maternal mortality. Early tools used during this time often resembled torture devices, which when not causing mortality would often cause multiple medical issues for the mother after birth as well. In the 1800s specifically, the most dangerous thing for a woman who was expecting a child was infection, mainly due to the lack of hygiene and knowledge on diseases that were transmissible. Women during childbirth would often develop puerperal fevers and other infections from midwives and doctors would avoid blame by lying on their death certificates as well as to mothers who survived, stating that they suffered or died from fevers or hemorrhaging, and not mentioning that it was caused by the childbirth itself. While some physicians acknowledged the lack of sanitation and hygiene when delivering babies, doctors were quick to dismiss claims. In the early 20th century, rich women actually died more frequently from childbirth than poor women because of this issue with sanitation and hygiene. As time progressed throughout history of childbirth and pregnancy, with technological advances in the medical field, new causes for maternal morbidity and mortality arose. Most notably, the usage of cesarean or C-sections became quite common, and while saving some women's lives who have died from obstructed labor, women would often die from blood loss and infection as well. In the 1930s, however, the maternal mortality and morbidity rates dropped due to the introduction of antibiotics, which were highly effective in treating infections like puerperal fever, which were primarily causing maternal mortality. Along with the introduction of antibiotics, reform in the medical field also helps contribute to the decrease in maternal mortality and morbidity rates. Doctors in particular received better training regarding childbirth, along with the emphasis of prenatal care becoming a standard part of medical practices. Also, with the creation of birth control and more accessibility to abortions, it has also lowered the rates of death due to unsafe abortions as well, as illegal or unsafe abortions was a leading cause of death for women historically. Despite the progression of the medical field and how childbirth and pregnancy is handled historically, women still face many barriers regardless of their race or economic status. Some of these barriers include accessibility and quality of care from healthcare providers, as well as accessibility to postpartum care as well. Along with accessibility issues, other common barriers include availability, affordability, and lack of knowledge on their reproductive rights and anatomy. Examining maternal morbidity and mortality, its causes and effects can not only be examined on a historical and international scale, but on a national scale as well. In particular, studying countries with high maternal morbidity and mortality rates will not only further help put into perspective the preventable causes of maternal morbidity and mortality, but also help conclude solutions to this issue as well. The first country of focus is the United States. Despite being one of the most influential and affluent nations globally, the United States has one of the highest maternal morbidity and mortality rates in comparison to other developed nations. In the US alone, for instance, 650 to 750 maternal deaths occur annually, with over 60,000 women each year affected by maternal morbidity. Many of these cases of maternal morbidity and mortality are preventable, as many women who are affected by mortality and morbidity often lack accessibility to care or have access to poor quality healthcare providers. Rates of maternal morbidity in particular are inaccurate in the United States and often lack rates of morbidity in prenatal and postpartum cases. The chart displayed gives us some statistics on prenatal and postpartum morbidity, with the most common prenatal morbidity being a miscarriage and the most common for postpartum being postpartum depression and endometriosis. In the United States, while maternal morbidity and mortality is common, it more commonly occurs in specific subgroups of women. In particular, the United States has a high racial and ethnic disparity in relation to maternal morbidity and mortality. For instance, the maternal mortality rate for Black women is 2.5 times higher than the ratio for white women, and 3 times higher than the ratio for Hispanic women. More specifically, Black women with college educations are 60% more at risk for maternal death than their white or Hispanic counterparts, who have less than a high school education. Along with Black women, Native American women also have a high rate of maternal morbidity and mortality. Research also shows that Hispanic and Black women have a higher risk of severe maternal morbidity, specifically with conditions such as preeclampsia, which is a common cause of maternal death as well. Along with race being a major factor in the high rates of maternal morbidity and mortality, socioeconomic status and geography are also major contributors. In the United States, socioeconomic status influences maternal health, specifically in urban areas such as Washington, D.C. and New York City. In these areas specifically, access to quality health care is a critical issue when discussing rates of maternal morbidity and mortality. For instance, a study performed by Washington, D.C. concluded that 97% of the free preventative health care services were underutilized due to the majority of its intended users lacking transportation to get to these facilities. Along with these urban areas, women in rural areas who are also low income are also at high risk of maternal mortality and morbidity as well. In particular, however, women living in poverty often experience significantly higher rates of maternal morbidity and mortality rates than the national average, possibly due to the lack of accessibility to prenatal care. Like race and socioeconomic class, geography is also a major contributor to high rates of maternal morbidity and mortality in the United States. Similar to socioeconomic class, geography is interdependent with race and socioeconomic status, as racial disparities in relation to maternal morbidity and mortality occur more frequently in southern states and other cities such as Atlanta, Georgia, and Jackson, Mississippi. While some southern states continue to pass strict abortion laws, these same states report high maternal morbidity and mortality rates as a result. For instance, states like Georgia, Louisiana, and Indiana have some of the highest maternal morbidity and mortality rates. But it doesn't stop there, as women who live in rural areas in the United States are 97% more at risk to die from childbirth or suffer from maternal morbidity in their lifetimes. Other factors that contribute to the high rates of maternal morbidity and mortality in the United States are education and environmental surroundings. Women without a secondary education, or less than a high school education, are much more likely to suffer from maternal mortality and morbidity. More alarmingly, however, are the environmental factors that affect the rates of maternal morbidity and mortality in the United States. As like other contributors, environmental surroundings are interdependent on the other contributors, such as socioeconomic class and race. For instance, low economic status and racial and ethnic minorities are often exposed disproportionately to chemical and non-chemical stressors environmentally, which can heighten the risk for maternal morbidity and mortality. These environmental factors not only affect women's health in terms of pregnancy and childbirth, but overall reproductive and general health, as these same women are at higher risks of infertility, hypertensive disorders during pregnancy, as well as high risks of breast cancer and metabolic disorders during their lifetime. The second country of focus in relation to maternal morbidity and mortality is Nigeria. In low-income countries typically, the maternal morbidity and mortality rate is substantially higher than other countries. According to the World Health Organization, the maternal mortality rate in Nigeria is 814 people per 100,000 births, with a lifetime risk of a Nigerian woman dying during pregnancy, childbirth, postpartum, or post-abortion being 1 in 22 chance. What is most alarming, however, is that nearly 20% of all global maternal deaths occur in Nigeria as well. While maternal morbidity and mortality is quite common in Nigeria, there are certain contributors similar to the United States that explain why Nigeria has such high rates of maternal morbidity and mortality. One of the most notable contributors is socioeconomic status, and more specifically the wealth gap in Nigeria. Women who come from low-income households are often the least likely to receive adequate health care due to accessibility issues and lack of funds to afford access to skilled healthcare workers. Due to this issue, Millions of Nigerian women often lack assistance from any trained healthcare professional during their prenatal, birthing, and postpartum processes, which explains why the rate of maternal morbidity and mortality is so high. Another contributor to the high rates of maternal morbidity and mortality rates in Nigeria is geography. Recent studies have shown that there are substantial differences in maternal morbidity and mortality rates in geographically north locations in comparison to southern locations, likely due to health disparities. For instance, from 2008 to 2013, maternal morbidity and mortality occurred slightly more frequently in north locations and decreased in southern locations. The increase in maternal morbidity and mortality in the north was linked to media coverage and education, while the south linked their decrease to contraceptive usage and their wealth ratio. These statistics are reiterated through the map of Nigeria from 2011, depicting higher rates of mortality in the north and lower rates in the south. Other factors that contribute to the high rates of maternal morbidity and mortality include educational barriers. Educationally speaking, while most Nigerian women obtain some form of education, the community perceptions of maternal morbidity and mortality and lack of knowledge on necessity for prenatal and postpartum care enable the high rates of maternal morbidity and mortality, usually leaving the poor and less educated the most vulnerable to experience it. Along with educational barriers, environmental factors also contribute to it as well. Poor access to water and sanitation contribute significantly to the rates of maternal morbidity and mortality in Nigeria, with as nearly as 57 million Nigerians lacking access to improved water sources and 130 million Nigerians lacking access to improved sanitation. Along with that, 25% of Nigerians practice open defecation on a daily basis, which greatly impacts the rate of maternal morbidity and mortality rates due to the increased potential in disease and sickness from a lack of sanitation and hygiene. Along with examining the United States and Nigeria, the cultural similarities and differences amongst women as a whole must also be examined in order to fully understand the causes of maternal morbidity and mortality on a local, national, and international scale. One of the most prevalent sociocultural factors that makes maternal morbidity and mortality an issue in the United States, Nigeria, and other countries as well is religious beliefs. For instance, Muslim women are more than 52% more likely to suffer from maternal morbidity and mortality in comparison to Christian women. Women who are also religious are more likely to not seek prenatal care, having a rate 3 times higher than the average for maternal morbidity and mortality in the US alone. Religious women are also less likely to utilize contraceptives and less likely to seek adequate care from healthcare providers, such as Planned Parenthood, due to religious shame. This leads to more frequent births, which in turn can increase the risk of maternal morbidity and mortality, due to the lack of knowledge on how to maintain a healthy reproductive system. This sociocultural issue is also interdependent to the substitution of modern medical practices due to traditional values and beliefs. While linked to a lack of education on modern medicine, in many cultures, women often attribute their sicknesses or illnesses during pregnancy due to cultural beliefs such as poisoning and witchcraft, and often don't seek medical attention, but instead seek religious figures such as churches. Another sociocultural factor contributing to this issue is gender dynamics and roles in society. Most cultures impose gender roles due to societal norms and expectations. Oftentimes, these norms affect the health of a pregnant woman, as their role in the household is related to the risk factor associated with maternal morbidity and mortality. Men often lack knowledge on pregnancy and the full scope of the dangers of carrying a child, and are often less likely to share workloads or emphasize the need for prenatal care to their wives or girlfriends. While not present in some cultures, women are often financially dependent on their male counterparts, and often lack the funds and transportation to receive adequate care, resulting in higher risks of morbidity and mortality. Despite the various factors that contribute to maternal morbidity and mortality in various cultures and countries, there have been numerous ethical considerations and actions taken on a local and global scale in order to help combat the rates of maternal morbidity and mortality globally. In the United States, for instance, local and federal government officials have passed and initiated various programs to help combat the high rates of maternal morbidity and mortality in the United States. President Donald Trump, for instance, during his presidency, authorized $60 million over a 5-year span to fund state maternal mortality review committees in order to improve data on maternal deaths to help further understand the preventable causes for future course of action. Along with this, under President Joe Biden and Vice President Kamala Harris, the White House Maternal Health Day of Action was initiated, as well as new investments to the Build Back Better Act that would help support safe pregnancies and childbirth, as well as reduce complications and mortality. In this bill specifically, it includes a $3 billion investment in maternal health, as well as an expansion on the coverage through Medicaid programs for prenatal and postpartum care, which already exists in states like Virginia, New Jersey, and Illinois. Along with providing continuous coverage, the bill also calls for the establishment of maternal health homes to better coordinate health care for individuals before, during, and after birth. In Nigeria, organizations such as Merck have created programs like Merck for Mothers dedicated to combating maternal morbidity and mortality. Merck has worked with Nigeria's local private healthcare sectors, which provide services to more than 60% of the population, in order to help solve preventable issues related to maternal morbidity and mortality. Since 2015, Merck has worked with Nigerian governments on pursuing new approaches to strengthening the healthcare system, as well as supporting maternal health as a whole. Along with Merck, the World Health Organization, as well as other partners, have begun supporting governments in Nigeria to develop guidelines and policies on reproductive and maternal health as well. Globally, there are various initiatives as well that are dedicated to combating preventable causes of maternal morbidity and mortality. One initiative is the Ending Preventable Maternal Mortality Initiative that was launched by the World Health Organization. This initiative was launched to help countries with some of the highest mortality rates and morbidity rates in the world, helping these countries establish better quality of care for women and establishing policies dedicated to reforming maternal health care as a whole. Along with global organization efforts, various nonprofit organizations are also dedicated to combating maternal morbidity and mortality. For instance, the nonprofit organization Every Mother Counts aims to make pregnancy safe for all mothers and has invested $20 million in public education, community engagement, and grant making, and has also established 29 programs in over 9 countries to improve the lives of mothers and healthcare as a whole. Another nonprofit dedicated to maternal health and combating maternal morbidity and mortality is the Bill and Melinda Gates Foundation. Their foundation's goal is to ensure women and newborns remain healthy before, during, and after childbirth through the support of development, testing, and initiative solutions to help address contributors to poor health. This team specifically supports work through national and regional facilities, global policies, and financial strategies to combat issues related to maternal health. Maternal morbidity and mortality continues to be a major human rights issue that has debilitating effects to women's health. Through understanding pregnancy and childbirth and its history in a medical context, as well as examining maternal morbidity and mortality in a concentrated context in nations like the United States and Nigeria, it will help further establish what these preventable causes for maternal morbidity and mortality are and allow for further advocacy and policy that can not only help decrease the rates of maternal morbidity and mortality, but positively affect women's health on a local, national, and international scale.